All right. So just to make sure, can somebody confirm that they can hear me?
Yep, can hear you.
Okay,
Yep.
great. Okay, so my name is Keaton Preble. My name is Keaton Preble. I'm a PGY1 here at Baptist Health and at Lexington, and I'll be talking about the updates for the treatment of antimicrobial resistant gram-negative infections. Okay, and in terms of disclosures, I do not have any. So our objectives today are first to differentiate between problematic antimicrobial resistant mechanisms and gram-negative pathogens, what organisms are most likely to carry them, and empiric therapy for each situation. Compare and contrast the previous guidelines to the 2024 IDSA guidelines. Analyze which high-risk populations are most likely to develop antimicrobial resistance, and finally, determine how pharmacists can support providers on when to use newer beta-lactam, beta-lactamase inhibitors, novel agents, and combination therapy. So in July of 2024, the Infectious Disease Society of America came out with updated guidance on the treatment of antimicrobial resistant gram-negative infections for several different resistant mechanisms and specific pathogens. And these include extended spectrum beta-lactamase producing Enterobacterales or ESBLEs, AMP-C producing Enterobacterales or AMP-CEs, carbapenem resistant Enterobacterales or CREs, Pseudomonas aeruginosa with difficult to treat resistance DTR Pseudomonas aeruginosa, carbapenem resistant Acinetobacter baumannii or CRAB, and then finally Cenotrophomonas multifida. So we've had certainly an emerging problem over the past several decades when it comes to antimicrobial resistance. And the World Health Organization in 2017 actually published a list of pathogens that were becoming of greater concern for antibiotic resistance. As you can see on the right here in this chart, there was quite a bit of ESBL Enterobacterales infections, and we just wanted to at least take a look at that, and we'll go through each of these as the presentation goes on, but I just want to have that in the back of your mind as to how big of a problem this actually is. And then also the Centers for Disease Control and Prevention, or the CDC, estimates that each year in the U.S., antimicrobial infections can cause greater than 2.8 million infections and greater than 35,000 deaths just with us having such resistant pathogens nowadays. So keep in mind throughout this presentation that resistance does not mean virulence. And what I mean by that is just because a pathogen just happens to have a resistance mechanism doesn't mean that it's more likely to cause serious disease compared to a regular isolate of the same pathogen. Also, the presence of resistance does not mean that we need to do an extended duration of therapy. So again, if we're going off of the logic of resistance does not mean virulence, as in it's not necessarily a more bad strain for a person to be infected with, then that doesn't necessarily mean that we're going to have a greater duration of therapy. And then finally, bacterial colonization does not mean infection. We have to look at how the patient is presenting as to whether they are symptomatic or showing some change in their vital signs, as to whether we should actually treat them. So in the cases of asymptomatic bacteriuria or superficial wound cultures. So our first question of the day is, which of the following agents cannot be used for an ESBL producing E. coli in uncomplicated cystitis? And I'll give you 20 seconds to do this. All right, so it's been 20 seconds. Okay, so our ESBLEs. So ESBLs, or extended spectrum beta-lactamases, are enzymes which can inactivate most penicillin, cephalosporins, and aztreonam. And I just want to keep you in mind with our ESBLs, since they are beta-lactamases, they're not going to inactivate our non-beta-lactam agents. So that means that we can certainly use some non-beta-lactam agents for the treatment of these in certain situations, which we'll get to in just a little bit. So our most common gene in the U.S. for ESBLs is our CTXMs, which can show up as great as like 85% in some areas. And also, in order to keep this in mind, organisms that have ESBLs also tend to carry additional genes which can expand their resistance to other antibiotics. So just to make a little note of that. And here are our most common pathogens that actually can harbor ESBL enzymes. So E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Proteus mirabilis, at least in terms of our national ESBL rates. And just as a little fun fact, ESBLs have actually had an increase in the U.S. from 2012 to 2017 of about 53%. So it's certainly significant and something that we need to be worried about. So in terms of how you should be looking at the treatment of ESBLs, I want you to try and put into two boxes here of whether it is a urinary tract infection or a different type of infection, so non-urinary. So in those cases, since this is a beta-lactamase or an extended spectrum beta-lactamase, we do want to try to use our non-beta-lactam agents if we are able to. So, such as our nitrofurantoin, trimethoprim, sulfamethoxazole, and single-dose aminoglycosides are certainly good options for most of these urinary infections. And we'll get to the details of those in just a moment. So as for fosfomycin, there's a little star here that says E. coli only. So that is something we'll get to in just a moment, but just make a little note for yourself there. And then our non-urinary infections, of course, we are going to have to use our more broader agents or some agents that we really don't want to have to use if we don't have to. So like our carbapenems and fluoroquinolones in our non-urinary infections. But at least for our urinary infections, try to use our non-beta-lactam agents if possible. So our single-dose aminoglycosides, or SDAG, as I've coined it here. So there was actually a systematic review of about 13 studies that looked at the usage of single-dose aminoglycosides. And 2 of those studies actually did include upper urinary tract infections, but most of these patients were just with cystitis. So they actually did find a decently high microbiologic cure rate of about 85% and an overall cure rate of about 95%, which is quite significant, at least in terms of us being able to use only a one-time dose of an aminoglycoside to actually help these patients that do have those true urinary tract infections. And even with having urologic abnormalities, they still had a pretty high cure rate of about 86.3%. I will mention that at least with the dosing of these, they were primarily weight-based. And the most commonly used agent in this was nettlemycin, which we don't really use here much. We don't really use in the States. But amikacin and gentamicin were also predominant in this review. I just want to at least make note of that. And in terms of the resistance with this, there were only 3 patients that actually had any resistance that were actually noted. Again, you will have to at least take note of the fact that most of these patients were female. Okay, next, let's talk about fosfomycin. So fosfomycin, of course, doesn't really have a great reputation in terms of being able to use for several different pathogens. Really, the only one that's been shown to actually be very well suited towards is E. coli. And this is because of the presence of the FosA gene, which is prevalent in most Enterobacterales, which hydrolyzes fosfomycin, but it's not very common in E. coli. And in a cross-sectional study of about 2,800 patients with urine cultures with susceptibility testing, cephalosporin-resistant E. coli was found to be susceptible to fosfomycin for greater than 90% of isolates. So it's actually pretty similar to nitrofurantoin. And treatment failure is more common with fosfomycin versus nitrofurantoin for our urinary tract infections. So at least in terms of us using it as a primary therapy, it doesn't seem to make sense, at least when we don't know which pathogen we're actually treating. So that's certainly one of the drawbacks with the usage of fosfomycin. But if we happen to have a patient that has an E. coli, then we certainly can play the better's game of using fosfomycin in those cases. And I do want you to at least mention that these resistance rates for fosfomycin were from a hospital system in Turkey. So that is something to take note of, because I could not find any specifics for resistance rates here in the United States. Okay, so now on to our non-urinary tract infections. So the trial I want to mention is about the Marino trial, which happened several years ago, which was a non-inferiority randomized clinical trial of a little less than 400 patients. And this was in ceftriaxone non-susceptible E. coli and Klebsiella pneumoniae bloodstream infections, which compared piperacillin tazobactam with meropenem for all-cause mortality at 30 days. So what they found was that there was a stark difference in the mortality rate of meropenem versus piperacillin tazobactam. So meropenem certainly seemed to be a lot more effective in these patients compared to piperacillin tazobactam. It was noted in the study, though, that both of these were administered using standard infusions rather than our extended infusions. So that is something to take note of, and there hasn't been a study that actually looked at the usage of extended infusions with piperacillin tazobactam. So it could be something in the future, but it's not anything that we can actually use at this time. So at the moment, carbapenems are preferred in our non-urinary ESBL-E infections. And to continue on that, in our critically ill patients having non-urinary infections with an ESBL-E, meropenem or imipenem cilastatin is preferred to ertapenem. And this is because ertapenem does have a higher clearance in patients with hypoalbuminemia, which is more prevalent in our critically ill patients. There was actually an observational study of about 279 patients with Enterobacterales infections. And basically what they found is that patients that had hypoalbuminemia, so a serum albumin of less than 2.5 grams per deciliter, actually had approximately a 5 times higher odds of 30-day mortality compared to meropenem or imipenem cilastatin. So for our treatment of ESBL-E takeaways, our non-beta-lactam agents are preferred in our ESBL-E urinary tract infections. Our carbapenems are going to be preferred in our non-urinary ESBL-E infections. And then finally, meropenem is preferred over ertapenem for treatment in critically ill patients with ESBL-E non-urinary tract infections. Okay, so next we'll be moving on to our next section. So RV is an 83-year-old male with bacteremia secondary to urinary source and has a blood culture which results in Klebsiella aerogenes. He's currently on Piptazo, 3.375 grams every 8 hours, but susceptibilities aren't back. What changes would you make to his antimicrobial therapy? And I'll give you 15 seconds. All right. So next we have our AMP-C beta-lactamases. So our most common pathogens that produce AMP-C beta-lactamases are our Enterobacter coliaceae, Klebsiella aerogenes, and Citrobacter fruendii. And as you can see right here, these are our production rates of AMP-C beta-lactamase in each one of these pathogens. So Klebsiella aerogenes seems to be, at least in this study from Europe, was the most likely to have the AMP-C beta-lactamase gene, or rather production. I do want to at least emphasize that with our AMP-C producers, it is very important to look at the species rather than the genus of the bacteria. So for example, Citrobacter fruendii does have chromosomal AMP-C, whereas Citrobacter cosseri does not. So even if you happen to see a Citrobacter isolate, that doesn't necessarily mean that they are an AMP-C producer. And if we can avoid using some of our other agents when we know that a isolate happens to be a less likely AMP-C producer, then we certainly would want to try to avoid agents that we don't have to use in those circumstances. So just want to put that out there. As for AMP-C production, there are actually 3 different mechanisms for having these beta-lactamases, which include constitutive overexpression, inducible chromosomal resistance, and then finally stable derepression. So here are the 3 different mechanisms. I'm not going to be going over all 3 of these. I'm going to be specifically talking about the second one, which is our inducible chromosomal gene expression. So say, for example, if you happen to have a urine culture that came back as an E. coli that was, no, I mean, a Enterobacter that came back as ceftriaxone susceptible on the original culture susceptibilities. So in that case, you might be like, oh, we can use ceftriaxone for this patient, and that'll be fine. Well, the patient will end up becoming a little bit worse over time. So you'll be wondering, well, what happened here? So what can happen is basically, as you can see in this figure right here, is that the beta-lactam actually would then be exposing to the isolate from the urine culture, or rather from that was in the patient's body. So basically, the bacteria would end up producing lots of AMP-C beta-lactamase to help break down that drug. So in that sense, you would have the drug not actually be able to work on the bacteria. So in that case, we actually need to use a different therapy. So basically, the drug is becoming resistant in the presence very fast, if you want to think of it like that. So in terms of our AMP-Cs, there was actually a recent update as to which organisms we should be concerned about AMP-C production. And this is because of several reasons. So with the previous acronym SPACE or SPICE, which included our Serratia, Pseudomonas, Acinetobacter, indole positive proteus species, Citrobacter, and Enterobacter cloacae, several of these organisms have been renamed or reclassified or are less likely to be harboring AMP-C resistance, now at a less than 5% occurrence. So there's actually been a recent update to this, and a new acronym was created called Heck Yes, which includes the organisms below, as you can see. Again, we do want to try to emphasize our usage of our non-beta-lactam agents if possible in these cases and separate between urinary and non-urinary infections. So again, harping on the potential for usage of our trimethoprim, sulfomethoxazole, nitrofurantoin, and single-dose aminoglycosides if we can in our urinary infections. And then we'll get to our non-urinary in just a moment. I do want to briefly talk about the induction of AMP-C just a little bit longer. So as you can see right here, there are several different drugs that have induction and stability. So if a drug is a strong inducer, then they will cause for the production of AMP-C to happen at a much higher rate, whereas the weak inducers won't really do so. The stability is just in regards to the drug itself in the presence of that enzyme, whether it will be stable or not. So with our agents, we do want to be sure that when we are choosing one, that they are stable even in the presence of AMP-C, if that were to be the case. So that's why carbapenems and cefepime are certainly looked at specifically in our bloodstream infections or our non-urinary tract infections. And there was actually a comparison of cefepime versus carbapenems, which looked at the risk of 30-day mortality for high-dose cefepime versus our carbapenems for treatment of Enterobacterales bacteremia with moderate to high risk of AMP-C production. And what they found was there wasn't really a difference in unadjusted mortality. There was actually a difference in duration of therapy with cefepime versus our carbapenems. And there was actually a shorter length of stay, both in regular hospital stay as well as in the ICU. And equivalents via renal function were accounted for as part of these. So in terms of our AMP-C key takeaways, infections caused by these organisms suspected to produce AMP-C are not defined by the genus, but by the species. And cefepime is going to be the preferred agent for suspected non-urinary infections caused by likely AMP-C producing organisms. And that's just because, again, if we can use a narrower agent, then we should try to do so if possible. Okay, so our next question, BB, a 85-year-old female critically ill with bacteremia and is currently on meropenem 1 gram every 8 hours. BTID detects Klebsiella pneumoniae with the NDM resistance genes. What adjustments would you like to make to her therapy? And I'll give you 15 seconds. All right. So our carbapenem-resistant enterobacterales, or CREs, which are defined as being resistant to at least one carbapenem or producing a carbapenemase enzyme. So these are divided into two separate subgroups, the carbapenem-producing CRE, or CpCREs, and non-carbapenemase producing CREs, or non-CpCREs. And the guidelines do mention about the resistance to at least one carbapenem other than imipenem is required for Proteus, Morganella, and Providencia species, so just as a little fun fact. So again, with our antimicrobial agents, we're really going to be looking at whether it's urinary infection or non-urinary infection. Again, just if we can spare the usage of our really broad beta-lactam agents, then we should certainly try to do so. And then in terms of our non-urinary infection agents, where we are going to end up potentially using our novel agents such as cefiderocol or our beta-lactam, beta-lactamase inhibitors such as ceftazidime, avibactam. I've shortened these to CZA, meropenem vaporbactam or MV, and imipenem cilastatin relebactam or ICR. As well as we do have tigecycline and ribociclib as part of these, but they aren't really used in our bloodstream infections due to the potential for increased mortality. So our non-CP CREs versus CP CREs. So our non-CP CREs can occur due to combinations of ESBL production and outer membrane porin disruption. And they're most commonly encountered in E. coli, Klebpneumo, E. cloacae, Citrobacter fruendii, and Serratia marcescens. Whereas our CP CREs consist of isolates that have typically one of 5 different enzymes, potentially more. The most commonly carbapenemase in the U.S. at least is the Klebpneumoniae carbapenemase, or KPCs. So just as something to keep in the back of your mind when it comes to our CRE isolates, there was actually a surveillance data collected on over 2,000 CRE isolates from 2016 to 2017. And they did show ertapenem monoresistance in about 62.2% of cases. However, even in the presence of this ertapenem monoresistance, most of these did not actually have a carbapenemase gene. So almost 98% actually did not have a carbapenemase gene. So that means that you could still technically use a carbapenem instead of using our beta-lactam, beta-lactamase inhibitors in certain situations. You could just use a meropenem or imipenem cilastatin instead of having to go super broad. And this is only, of course, if susceptibility to other carbapenems is retained. So in those situations, you would want to use an extended infusion. So as for our carbapenemases, we do have a few different classes here. So we have our serine beta-lactamases and our metallo-beta-lactamases. So our serine beta-lactamases include our class A and our class D, and our metallo-beta-lactamases include our class B. So our class A are Klebsiella pneumoniae carbapenemases. Our class B includes New Delhi metallo-beta-lactamase, or NDMs, Verona integron encoded metallo-beta-lactamases, or VIMs, or our imipenemase metallo-beta-lactamase, or IMPs. And then finally, our class D are oxycylinase 48-like beta-lactamase, or OXA48s. So you might be thinking, wait, where is class C? So class C is actually our AMP-Cs, and they just hydrolyze cephalosporins primarily. So our serine beta-lactamases actually have serine in the active sites in order to help with the hydrolysis of the beta-lactam, whereas with our metallo-beta-lactamases, they'll have a zinc in the active sites to help with the hydrolysis. Okay, so our KPC, again, it's a serum beta-lactamase, and here are our current pathogens that are most likely to harbor that. Of course, as you would expect, Kleb pneumoniae is going to be our number one. E. coli and Enterobacter and Serratia marcescens are certainly going to be big players. I do want to also mention that KPCs can also be seen in Pseudomonas aeruginosa and Acinetobacter, but they aren't as commonly seen. In terms of our therapeutic options, certainly can do ceftazidime, avibactam, imipenem, cilistatin, relebactam, meropenem, vaborbactam, or cefiderocol. Our OXA48, again, one of our serine beta-lactamase. It does have a high transfer efficiency of plasmin, so it is able to move around quite a bit between isolates, so it's just something to keep wary of. And as you can see right here, our most common pathogens, Klebpneumo, Enterobacter, Citrobacter, and Salmonella, interestingly enough. So it is a little bit more limited, at least in terms of our therapeutic options compared to our KPCs. So ceftazidime, avibactam, and cefiderocol. So our meropenem, vaborbactam, and imipenem, cilistatin, relebactam aren't really usable with our OX48s. So it's just something to keep in mind. And then, of course, our NDM, VIMs, and IMPs are metallo-beta-lactamases. So these are some really nasty enzymes. And as you can see right here, I've divided each one of the resistance genes into their various pathogens they're most likely to see in. The one that I'm most, of course, concerned about is with our Pseudomonas aeruginosa. And I will take note of the fact that VIM is the most common metallo-beta-lactamase among Pseudomonas, but they're relatively rare among other bacteria. It's just something to take note of. In terms of our therapeutic options, we do have to go super broad typically with these. So ceftazidime, avibactam, plus aztreonam, or cefiderocol. And this is just because metallo-beta-lactamases hydrolyze all penicillins, cephs, and carbapenemases, whereas aztreonam is able to at least block these. So in terms of our situations for newer agents in CRE infections, there was a prospective observational study which included over 100 patients with bloodstream infections caused by a metallo-beta-lactamase producing Enterobacterales. And this compared the usage of ceftazidime, avibactam, plus aztreonam compared to other antibiotics. So in terms of what they use for those other therapies, they consisted typically of either a colistin or a tigecycline-based therapy in combination with aminoglycosides, meropenem, zosyn, aztreonam, or fosfomycin, interestingly enough. There was a quite significant difference in the 30-day mortality and length of stay with the ceftazidime, avibactam, plus aztreonam group. So it's just something to take note of. In terms of the dosing with this, it did need to be dosed at least every 8 hours, preferably every 6 hours with aztreonam for that. So it is quite frequent. In terms of our CRE takeaways, the usage of our novel beta-lactam, beta-lactamase inhibitors in non-urinary infections and non-beta-lactam agents in our urinary infections. And I did create this little table to help guide you as to which agent you should use in certain circumstances. Okay, so next question. CP is an 89-year-old male in the ICU with pneumonia, is currently receiving piperacillin tazobactam 4.5 grams every 8 hours. His sputum culture grows Pseudomonas aeruginosa and susceptibilities result. What adjustments would you make to his antibiotic regimen? And I'll give you 15 seconds. All right. So First, I do want to talk about the difference between multi-drug resistant, or MDR, versus difficult to treat resistance, or DTR, Pseudomonas aeruginosa. So MDR basically refers to where Pseudomonas aeruginosa is not susceptible to at least one antibiotic in at least 3 classes. So, for example, if you had an isolate of Pseudomonas that was resistant to cefepime, meropenem, and levofloxacin, for example, then that would be considered MDR. Whereas Pseudomonas aeruginosa that is considered DTR would be non-susceptible to all that you see listed on the slide. And in those rare isolates of Pseudomonas aeruginosa that do show non-susceptible to our carbapenems, but are susceptible to a traditional beta-lactam such as piperacillin tazobactam, they can be used. That piperacillin tazobactam could be used in those situations, but only if they show susceptibility, and would be highly recommended to use a high-dose extended infusion therapy. So again, looking at our antimicrobial agents, splitting them up into urinary infections and our non-urinary infections. So we do have a new agent that we can use. Ceftolozane tazobactam gets added to our beta-lactam, beta-lactamase inhibitors for difficult to treat Pseudomonas aeruginosa, and several of our old friends from the previous section, as you can see. And then, of course, a single dose aminoglycosides can be used in our Pseudomonas aeruginosa, albeit amikacin or tobramycin are suggested for this due to the breakpoints with gentamicin. Okay, so the primary trial that I'm wanting to talk about in this section is the Cactus trial, which matched multi-center observational study of 420 patients, or 210 pairs. And this compared the usage of ceftolozane tazobactam versus ceftazidime avibactam in MDR, Pseudomonas aeruginosa pneumonia, or bacteremia. And most of these patients did have pneumonia, but there was a good chunk that were bacteremia patients. So there was a prolonged infusion with both of these, more so with the ceftolozane tazobactam versus ceftazidime avibactam. There was also suboptimal dosing with the ceftolozane tazobactam, and yet there was still overall clinical success with these with the ceftolozane tazobactam difference, at least compared to ceftazidime avibactam. Both of them certainly worked to a pretty decent amount, and there was actually a bit of a difference specifically in pneumonia for ceftolozane tazobactam compared to ceftazidime avibactam. Whereas with our bacteremia patients, there wasn't really a difference. And there was a bit of a difference in terms of our immunocompromised patients. So despite having suboptimal dosing and a greater percentage of patients with immunocompromise, ceftolozane tazobactam actually seemed to still perform better. So there actually could have been a much bigger difference in this and potentially being a much preferred agent. So in terms of continuing on the Cactus trial, the ceftolozane tazobactam was actually associated with a lower odds of recurrent MDR Pseudomonas aeruginosa infections at 90 days, but it wasn't clinically significant. And at least in terms of the increased dosing, it was due to the usage of lower doses due to the usage of 1.5 grams every 8 hours in patients with pneumonia. And then in terms of the susceptibility testing that was performed, there were repeats of the susceptibility testing. So just to take note of that. As for our ceftazidime versus ceftolozane, there is a little bit of a difference here. So ceftolozane is less affected by PDC hydrolysis and porin loss compared to ceftazidime. So PDC is a type of beta-lactamase that forms an acyl complex with ceftazidime, but can't accommodate ceftolozane due to it having a longer R2 side chain. So that does make a difference in terms of hydrolysis. As well, ceftolozane actually does have activity against DTR Pseudomonas aeruginosa, even without tazobactam, whereas ceftazidime relies on the avibactam to avoid hydrolysis. So our DTR Pseudomonas aeruginosa key takeaways. DTR Pseudomonas aeruginosa is more resistant than MDR Pseudomonas aeruginosa. Both ceftolozane tazobactam and ceftazidime avibactam are appropriate options for DTR Pseudomonas pneumonia and bloodstream infections. However, ceftolozane tazobactam may be preferred empiric option based on the results from the Cactus trial. Okay, so next we have BG, who is a 78-year-old male who has returned from vacation after snorkeling in fresh water. BG has been on a ventilator for 3 days now, and BG has a past medical history of COPD, heart failure, diabetes, and rheumatoid arthritis. What are BG's risk factors for contracting CRAB? Select all that apply, and I'll give you 15 seconds. All right. So our carbapenem-resistant Acinetobacter baumannii, or CRAB. So Acinetobacter baumannii is associated with being in aquatic environments, and it does have an increased incidence in troops returning from conflict zones. So just a little fun fact there. And CRAB is an opportunistic pathogen associated with hospital-acquired infections. So think of our patients that are going to be in the hospital for a long time, potentially on the ventilator, and specifically for patients who are hospitalized greater than 90 days, CRAB does have a tendency to show up in those patients, as well as patients that have a high incidence. They do have a high incidence in patients who are immunocompromised. So there are several challenges to treatment of CRAB, as it does have multiple types of possible resistance mechanisms, including ESBLs, carbapenemase production. It does have efflux pumps on both beta-lactams and fluoroquinolones specifically, as well as heteroresistance to polymyxin B. It does have capsular enhancement, so that means that it forms a mucoid phenotype, which influences both its virulence and its fitness. So it certainly becomes more virulent and thus more infectious, as well as becoming more resistant to any sort of agent that we try to put against it. This also does protect against immune recognition and does have increasing clinical severity. And then finally, it does have the potential for biofilm formation. So thinking of our patients that end up having like osteomyelitis, having some sort of hardware, from some sort of orthopedic procedure, those sorts of things. In terms of our antimicrobial agents, we are a bit limited to some very broad agents, some very novel agents. So we do have sulbactam, durlobactam, or SD, high-dose ampicillin sulbactam, or HDAS, our polymyxins, high-dose minocycline, HDM, as well as cefiderocol. So the first trial I want to talk about with CRAB is the ATTACK trial, which happened a couple years ago, which was a multi-center non-inferiority clinical trial, which had patients with CRAB pneumonia or bacteremia. And it looked at the usage of sulbactam, durlobactam versus colistin in combination with imipenem cilastatin. So all patients did receive imipenem cilastatin, but they ended up also getting either sulbactam, durlobactam, or colistin. So there was a difference in mortality with these patients, as well as there was clinical cure, a bit of a difference there. They also did mention during the trial that there were monomicrobial infections as well as polymicrobial infections. So we did see that there was a bit of a difference in terms of our monomicrobial clinical cure. So just having CRAB as the only pathogen in this patient, whereas with our polymicrobial infections, so having more than one pathogen in this infection, there was actually not really a difference. So just to take note of that. In terms of our high-dose ampicillin sulbactam, so there isn't too much data as to the usage of this but in terms of it being effective, at least, it does seem to show promise. It's just in terms of the actual literature, it does need some additional looking into. There wasn't really a difference in terms of our 18 gram versus 9 gram and our 24 gram versus 12 gram in terms of our clinical improvements. But strangely enough, there was greater bacteriologic success with our 18/9 gram compared to our 24 gram/12 gram. And this was in a randomized prospective trial of 27 patients with MDR Acinetobacter baumannii ventilator-associated pneumonia. The overall mortality was still a decent amount, as well as our all-cause 30-day mortality was still quite significant. But it is a good option for us at the moment. In terms of our high-dose minocycline, there was actually a retrospective study of a little over 200 patients with Acinetobacter baumannii infections, and they either received minocycline or alternative treatment. And that alternative treatment was other antibiotics, typically either cefepime or meropenem, but there were other agents. And the high-dose minocycline dose was minocycline 200 milligrams IV every 12 hours. In terms of our polymicrobial infections, at least there wasn't anything significant in terms of a difference, at least when they calculated the p-value. In terms of our lack of clinical response, again, there wasn't really a difference there. In terms of our duration of therapy, it was lower with our high-dose minocyclines compared to alternative treatment, as well as a shorter length of stay with high-dose minocyclines. So in terms of the literature with it, it does seem like a possible agent to be used, but not something that we could use as monotherapy. And in terms of the actual patients themselves, the infections that they typically had were respiratory, and there weren't really any urinary infections with that, and that is due to the low urine concentrations with high-dose minocycline. So our CRAB's key takeaways is that sulbactam durlobactam is IDSA's preferred regimen in combination with carbapenem. However, high-dose ampicillin sulbactam is an alternative therapy that can be used and is our health system's preferred agent with our current system formulary. High-dose minocycline could be used as an adjunctive agent in combination with other therapies, so it's certainly something we can look into in that sort of sense. And then our final question here, which of the following are preferred antibiotics for the treatment of Cenotrophomonas multifida pneumonia? There are multiple answers to this, so I'll give you 30 seconds. Okay, so Cenotrophomonas multifida. So I just love this figure. It really shows how much of a pathogen that it is. It has a lot of barriers for us to try to breach. It has potential for biofilm formation, adhering to surfaces. It has a lot of virulence, potential for a lot of different types of antimicrobial resistance, whether that's reduced permeability, inactivation, efflux pumps, modification, you name it. In terms of our risk factors for mortality with Cenotrophomonas multifida, ICU admission, septic shock, need for mechanical ventilation, or indwelling catheters, any sort of immunocompromise is severely supported for high mortality with Cenotrophomonas multifida, so that's just something to take note of. And I thought that it would be pretty cool to just see our system-wide systemic susceptibilities right before we go into which agents we can use. So primarily we do look at levofloxacin and trimethoprim sulfamethoxazole for Cenotrophomonas. And we do have some pretty decent susceptibilities outside of Lagrange, which only had 2 isolates, so it's kind of hard to really tell there. but at least in terms of the isolates that we did get over the past year, we do have pretty good susceptibilities, which is nice to see. Madisonville wasn't up to date, and there weren't any isolates from Richmond, so they were not included in this figure. In terms of our antimicrobial agents, again, we want to split everything into our urinary and our non-urinary infections. So with our urinary infections, we do have the usage of either ceftazidime avibactam plus aztreonam, or two of the following, cefiderocol, levofloxacin, and trimethoprim sulfamethoxazole. So you want to use two of those three agents in those situations. Or with our non-urinary infections, we can certainly do ceftazidime avibactam plus aztreonam, or again, two of the following. And again, that high-dose minocycline in that two of the following is just with our non-urinary, just because of the low concentrations. And then tigecycline has been removed as a component of combination therapy just due to the high mortality associated with it. So our ceftazidime avibactam plus aztreonam combination. So Cenotrophomonas multifida does have two notable beta-lactamases that I do want to take note of here, L1 and L2. So L1 actually will hydrolyze ceftazidime avibactam, but it doesn't hydrolyze aztreonam, whereas L2 hydrolyzes aztreonam but doesn't hydrolyze avibactam. So if you think about it, just being able to block both of those at the same time certainly can pay into our favor of treating the patient. And there was actually a review of over 1,800 isolates from all geographic regions over a 3-year period. And for isolates that were not susceptible to trimethoprim sulfamethoxazole, they were still quite susceptible to the combination of aztreonam plus avibactam at an MIC of 8 milligrams per liter. However, even with that, though, it's still not enough to make a meaningful analysis. It's just something to take note of. And as you can see, these are the regular susceptibilities among that group. In terms of our cefiderocol, there actually has not been a good study in humans like comparing between agents. So I had to do a study comparing cefiderocol with trimethoprim sulfamethoxazole in neutropenic rabbits for Cenotrophomonas multifida pneumonia, and this looked at mortality. The duration of therapy was at 10 days, and the primary outcome was with survival to 11 days. So there was a large difference in terms of the mortality of these rabbits with cefiderocol compared to trimethoprim sulfamethoxazole, and that's just something to take note of. Again, this was monotherapy, and there hasn't really been a good comparative study or any study at all in humans as of yet with Cenotrophomonas multifida. In terms of our key takeaways with Cenotrophomonas multifida, it is very resistant to many types of antibiotics. So the usage of either the combination of ceftazidime avibactam plus aztreonam, or a combination of two of cefiderocol, levofloxacin, high-dose minocycline, or trimethoprim sulfamethoxazole is preferred. Okay, so let's go back through all the questions and see how everyone does. So, question 1, which of the following agents can't be used for ESBL producing E. coli in uncomplicated cystitis? And I'll give you 10 seconds. All right, so our correct answer is B. And this is because of ceftriaxone's tendency to be hydrolyzed by ESBLs. So this is a ESBL producing E. coli in uncomplicated cystitis. So you can use piperacillin tazobactam as long as the patient's going to be is responding, and it, of course, is due to the concentrations in the urine. Fosfomycin, again, E. coli does not tend to have the FOS-A gene. Etripyrantoin, again, always a good option with E. coli. And gentamicin as a one-time dose, again, with the high microbiologic cure rate and overall cure rates, can certainly be used. Okay, so question 2. RV, an 83-year-old male with bacteremia secondary to urinary source and has blood culture which results as Klebsiella aerogenes, currently on Piptazo, 3.375 grams every 8 hours. Susceptibilities are not bad. What changes would you make to his antimicrobial therapy? I'll give you 10 seconds. All right, so the correct answer is B, and this is due to not being hydrolyzed by AMP-C. Cefepime is very stable in the presence of AMP-C. Of course, our Piptazo can be hydrolyzed. Ceftriaxone, again, hydrolyzed. Increasing the dose won't really do anything. And if we can avoid fluoroquinolones, then we certainly would like to try to do so. Okay, next question. BB, an 85-year-old female critically ill with bacteremia and currently on meropenem 1 gram every 8 hours. BCID detects Klebpneumo with the NDM resistance gene. What adjustments would you make to her therapy? I'll give you 15 seconds. Okay, so the correct answer is B. So switching to ceftazidime, avibactam plus aztreonam by being able to cover for those resistances, ceftazidime, avibactam in combination with aztreonam has been associated to be much better. Increasing the dose won't really do anything with this gene. Cefiderocol, of course, that increased potential for mortality, and then meropenem, avibactam isn't really that suitable in that sense. Okay, next question. CP, an 89-year-old male in ICU with pneumonia, currently receiving Piptazo, 4.5 grams every 8 hours. Sputum culture grows Pseudomonas aeruginosa and susceptibilities result. What adjustment would you make to his antibiotic regimen? And I'll give you 10 seconds. Okay, so our correct answer is C. So ceftolozane tazobactam, just due to the results of the cactus trial, since he does have pneumonia, and the fact that with proper dosing, at least it would imply the usage of ceftolozane tazobactam as preferred anyways. It was already a difference in that sense, but certainly preferred overall. So next question. BG is a 78-year-old male who has returned from vacation after snorkeling in fresh water. BG has been on a ventilator for 3 days now. BG has a past medical history of COPD, heart failure, diabetes, and RA. What are his big risk factors for contracting CRAB? I'll give you 10 seconds. All right, so the correct answers are A, B, and C. Because of his recent exposure to fresh water, currently ventilated greater than 48 hours, and has a history of rheumatoid arthritis, so he is immunocompromised. Okay, and then final question. Which of the following are preferred antibiotics for the treatment of Centromonas multifida pneumonia? Multiple answers. And I'll give you 20 seconds for this one. Okay, so this one is a bit of a trick question. So you can do E alone, as well as a combination of two from A through D. So technically all would be correct as long as you use a combination of two of A through D, as well as E already being correct. And this is due to the lack of a preferred agent at this time. So overall, our key takeaways is that gram-negative organisms are more prone to having resistance, but proper stewardship response can help reduce further resistance. Resistance does not equal virulence. And then finally, newer beta-lactam, beta-lactamase inhibitors, and novel agents such as cefiderocol should be reserved for situations where there are limited options. Here are my references.